Okay. আজকে একটু লম্বা টপিক আছে. The first one is PID, the second one is vaginal discharge. Infections in gynecology. Okay. So we'll start with PID. PID is basically an infection or inflammation. Okay, we're starting, huh? PID is an infection or inflammation of the upper genital tract. The upper genital tract consists of, starts from the internal os to the, from the uterus, cervix, internal os, the tubes and the ovaries. Any infection that occurs, whether it is sexually transmitted infection or infection because of iatrogenic DNE after delivery, after any kind of operations of gynecology, those are included in the PID. It includes cervicitis, it includes endometritis, it includes your salpingitis, tubo-ovarian abscess, peritonitis, all of these. Anything above the internal os. Risk factors. These are simple. Risk factors for any sexually transmitted infections are younger age of sexual intercourse, low socioeconomic status, multiple sexual partners, lack of use of barrier contraceptives, smoking, MTP, IUD insertions, HSG, hysteroscopy, etc. Your infections in PID occur because of both endogenous spread, that is spread from bacterial vaginosis or spread from any vaginal infections upwards through the genital tract, or it can occur because of external instrumentation of the uterus, because of DNE or any kind of HSG. Most common organism are these two. You have to remember these two names, Chlamydia and Neisseria. Okay, the most common organisms are Chlamydia and Gonorrhea. These are very important. We will treat only these organisms. This one organism, actinomyces, is useful for your viva. This is an organism that is responsible for PID after insertion of copper teeth. How does a PID patient present to you? A PID patient mainly presents to you with lower abdominal pain and fever. Any sexually active woman in her reproductive age group presenting with lower abdominal pain and fever, along with any of the other symptoms, your dyspareunia, menstrual irregularities. Anyone knows what's dyspareunia? What is dyspareunia? Pain during sexual intercourse. Your menstrual irregularities, cervical vaginal discharge or dysmenorrhea. What is this? Fitz-Curtis syndrome. What is Fitz-Curtis? What happens in that? What happens in Fitz-Curtis? Kothay infection hoy? Which body part is infected in Fitz-Curtis syndrome? No. Above or upward? Okay. Let me show you what Fitz-Curtis is. This one. What is this organ? What is this organ in laparoscopy? What is this organ? নিচে লেখা আছে পড়, নিচে লেখা আছে তো। মানে what is the organ? Liver. Adhesions between the liver and the diaphragm. It's a very unique case where a genital infection causes adhesions over the liver. That is called a Fitz-Curtis syndrome. Okay. What are the symptoms of PID? Lower abdominal pain, fever, dyspareunia, any kind of menstrual irregularities, be it oligomenorrhea or polymenorrhea. It can cause postcoital bleeding, abnormal vaginal or cervical discharge, dysuria and tenesmus, this one, Fitz-Curtis and dysmenorrhea. When you examine a patient of PID, what will you find? Number one is fever. Fever along with dry, toxic look, tachycardia, high, low volume pulse. This one, on PV examination, there is cervical motion tenderness, there is adnexal tenderness and uterine tenderness, and friability of the cervix and the vagina. Okay, this is a CDC criteria, Center for Disease Control. This is the criteria for diagnosing PID. We have some minimal criteria, additional criteria, as well as your definitive criteria. The minimal criteria, as I said, is pain in a lower abdomen in a sexually active woman, along with any of the three: uterine tenderness, adnexal tenderness, or cervical motion tenderness. This is the minimum criteria you need to diagnose PID. Since PID is a polymicrobial disease, it does not act a single organism diye hoy na, and its diagnosis is very difficult. Definitive diagnosis is very difficult. You need an endometrial biopsy for this. You need a TVS which shows proper fluid-filled tubes. It shows free fluid in the peritoneum as well as tubo-ovarian abscesses or mass. And the gold standard is a laparoscopy which shows thick, edematous, hyperemic tubes. The tubes are thickened. It contains increased vascularity on the tubes. There is fibrinous exudate, deposition of fibrin on the tubes, deposition of fibrin on the uterus. There may be tubo-ovarian masses. There may be ovarian masses. There is pelvic abscess, all of this. This is the gold standard in laparoscopy. But যেটা সবাই বুঝতে পারি, laparoscopy is both expensive as well as risky. একটা পেশেন্ট আউটডোরে আসলো, হঠাৎ করে তাকে তুলে নিয়ে laparoscopy করতে যাব না নিশ্চয়ই. It's a difficult procedure. So what I need is, my diagnosis requires only this part: lower abdominal pain along with any of the three things. I'll stamp her as PID and I'll start her treatment. I don't wait for any of this. I don't even wait for biochemical or microbiological definitive diagnosis. Because if I wait, there is lots of complications of PID. Amra keno wait korchi na? Why are we in a hurry to treat a PID patient? She's not going to die out of PID. But we are in a hurry because it causes lots of long-term complications. This one. A PID patient may land up into pelvic abscess. She may land up in tubo-ovarian abscess. She may land up with subfertility. Very, very important. Once the tubes are infected, the tubes are deranged, damaged, it causes subfertility. Long-term subfertility, which is almost non-treatable. Chronic pelvic pain, and it predisposes the patient to future ectopic pregnancies. To prevent all of these complications, I am going to treat her as soon as I get her. See, the other additional criteria would be presence of abnormal cervical or vaginal discharge present. Once we take the discharge and we put it under a microscope, wet mount microscopy of the discharge, I'll see multiple WBCs, increased amount of leukocytes, blood reports of elevated ESR, CRP in any infections which are positive, and finally I'll get laboratory documentation of gonorrhea or chlamydia, either by nucleic acid amplification test or by culture. This is what a laparoscopic image of any PID looks like. These are the fibrinous adhesions. See, fibrin deposits on top of the uterus, ovary. This is a tubo-ovarian mass here, this one, adhesions, and this Fitz-Curtis perihepatic adhesions. Treatment. How do you treat a PID case? As I said, the important organisms are chlamydia and gonorrhea. What is the treatment for gonorrhea? What is the treatment for gonorrhea? Microbiology hoye geche nischoi. What is the treatment for gonorrhea? And oral? Ceftriaxone and oral. Ceftriaxone is injectable. What is the oral treatment for gonorrhea? Doxycycline. Very good. What else? Azithromycin. Remember azithromycin? 1 gram stat dose. Yes. This one. This is the CDC guideline. This is not Indian guideline. This is CDC guideline. Management of outpatient management of PID and inpatient management. কাকে আমি আউটডোর বেসিসে ওষুধ দিয়ে ছেড়ে দেবো, কাকে আমি ভর্তি করব। Your patients which require admissions are patient in severe pain, patient not responding to oral tablets, patient not tolerating oral tablets, patients with tubo-ovarian abscess, or patients who have high risk of pregnancy. These are the patients that you will admit. Once she is admitted, you will give her this medication: ceftriaxone 2 gram along with doxycycline and metrogyl. Doxy is 100 milligram BD, Metrogel is 400 milligram BD. All of this intravenous. We'll give it IV till the patient recovers, her fever subsides, and clinically she is better for at least 24 hours. After that, I'll shift her to oral tablets. The another regimen is clindamycin and gentamicin. Dosage to the lagbena, just remember the names. Ceftriaxone along with doxy and metro, or we can go for clindamycin along with gentamicin. These are the inpatient managements. And the other one is the outpatient management. This is important. Amader Indian guidelines so etai ache. 500 ceftriaxone along with doxy and metro. This is what we do. Amra etai di patient ke ha. What we do in our setup in India, in any of the resource poor countries, what we do is we give something called a syndromic management. PSMA bola che syndromic management of infections. We don't wait for laboratory diagnosis. A patient comes to you, you see her symptoms, check her clinically, and you don't wait for laboratory investigations in order to diagnose and confirm your diagnosis. We directly treat her. This is known as syndromic management. Why are we doing this? It saves time, number one. It saves time, it saves resources. A laboratory investigations for a chlamydia or gonorrhea is very expensive and time consuming. So it saves that. You can treat your patient in single visit. Gynecology is a sensitive topic. Patients might come to you once, she might not come back again if you don't treat her. If she'll go somewhere else or she'll just sit in her home waiting for the complications. So you treat the patient in one visit, don't spend on laboratory investigations, and you treat for all the pathognomic organisms together. We give something called a Kit 6. The National AIDS Control Organization has devised 6 kits. Kit 1 থেকে Kit 6 of the high. The Kit 6 is for PID, the yellow kit. It contains 3 things. 1 single tablet of cefixime, 400 milligram. This one you need to remember. 1 single tablet of cefixime, 400 milligram, and 14 days course of doxycycline, 100 milligram BD, and 14 days course of Metrogel, 400 BD. Okay, this is what you need to remember for Kit 6. Amra jekono government outdoor etai di, we write it as Kit 6. এখানে কেন পুরো all over India যেকোনো government OPD তে PID patient আসলে Kit 6 ই লেখা হয়. This is what is given to the patient. What else do you need to do? এইটা লিখিস না. You don't remove the IUDs, huh? If the patient is having an intrauterine device, a copper T in situ, you don't wait for removal of that. ঠিক আছে? Does not require removal. Don't write this. Advise abstinence. You tell the patient that till you are cured or till you finish your course, you cannot go for unprotected sexual intercourse. Number 3 is you have to treat the partner. Since PID is an STD, a sexually transmitted disease, you have to treat the patient. You have to treat the partner and educate on the use of barrier contraceptives. As I said, these are the complications of PID. The important one is a pelvic abscess. Pelvic abscess is their short note hishabe ashe. What is a pelvic abscess? Anybody? What is a pelvic abscess? Jore bol jore. Ki hoy? Abscess mane ki? Collection of pus. Collection of pus. Pelvic abscess mane collection of pus in the pelvis. Simple as that. What happens is pelvis mane hoche POD, pouch of Douglas. That is the dependent part of the pelvis. Sekhane there is collection of pus. Why does it happen? Number 1, because of spreading infections from PID. PID infection extensively spread korche. Pelvic peritonitis hoche, salpingitis hoche, followed by pelvic abscess. Or it can happen after any kind of abdominal surgeries. Any abdominal surgeries, you leave a lot of blood inside. The blood forms an nidus for infection, causes lots of infection, suppurative pus formation. Also, it can occur after D&D, after criminal abortion, or even after any HSG or hysteroscopy. This patient will come to you as high-grade fever, cyclical high-grade fever, okay, and with chills and rigor. Patient also complains of, oily, frequent diarrhea, rectal tenesmus, dysuria, increased frequency of micturition, and even incontinence. Why? An abscess is forming in the pelvis. It is compressing both the rectum and the bladder. Compression on the bladder causes increased frequency of micturition, dysuria. On the rectum causes tenesmus. Okay. How do you treat case of pelvic abscess? Number one, you have to give her antibiotics and you have to drain the abscess. Drainage kotha diye hobe? Pelvic abscess. Antibiotics, so as usual, jeta bolllam, PID antibiotics, the same antibiotics works for them, but you have to drain the abscess. Where do you drain the abscess from? Kothay katbi? Hi, inguinal region e kete pabi, pelvis pabi, maje ki porbe? What is the easiest way to the pelvis? Yes, where in the vagina? Posterior colpotomy. Posterior fornix, you do a single small incision, you put a pictal catheter inside it and you drain all the pus from there. Okay, this is all about PID. Before I shift to the next topic, any questions on PID? Any questions on PID? No? Okay. I'll just revise it a little bit. ছোট কটা জিনিস বলে রাখছি শোন পরীক্ষার দিন তোকে PID থেকে দুটো কোয়েশ্চেন করবে একটা লং কোয়েশ্চেন there will be clinical scenario where the patient presents to you with what do you say a patient presents to you with lower abdominal pain fever and she's a sexually active female. How do you diagnose and what do you do? This is your major question. You will diagnose by these are your বন্ধ করে দিয়েছেন আরেকবার অন করুন PID বলে লেখা থাকবে দেখুন এনিওয়েজ যতক্ষণে করছে আমার বলা হয়ে যাবে The patient presents to you with lower abdominal pain, fever, along with some of the other symptoms. CBC raise thakbe, leukocytosis thakbe. Your investigation and your management. The first investigation that you do in a patient of lower abdominal pain in a reproductive age group is a urine for pregnancy test. The first thing you do is a pregnancy test. Why? To rule out ectopic pregnancy. An ectopic pregnancy will come to you with the very similar symptoms. Small history of amenorrhea, lower abdominal pain, might complain of fever, dysuria, etc. Also, then you do a blood test for CBC, ESR, CRP. As I said, the diagnosis is done by cervical smear with wet mount microscopy for gonorrhea and chlamydia. Gram strain of gonorrhea presents with gram-negative diplococci, whereas chlamydia is gram-positive. এইটুকু মনে পড়ছে তো? Chlamydia is gram-positive, whereas gonorrhea is gram-negative. Diplococci, gram-negative diplococci. You can do a nucleic acid amplification test, the most expensive and the most sensitive specific test currently in NAT, nucleic acid amplification test for both gonorrhea and Neisseria, and then you can go for laparoscopy. Short note for pelvic abscess. The other question that you get is syndromic management of PID. You have to write what is syndromic management, why do you prefer syndromic management, what are the advantage and disadvantage, আমি এই স্লাইডে বলবো এটা syndromic management and what are the other diseases that you can treat with syndromic management. পারবি পরীক্ষার দিনে? The next topic is vaginal discharge. Vaginal discharge can be both physiological as well as pathological. Physiological vaginal discharge is something that occurs naturally for all women. It can be, it is variable in amount. Karur jonno little vaginal discharge can be troublesome, while for others, profuse discharge is considered normal. It usually consists of this vaginal transudate. It consists of sloughed out epithelial cells, superficial squamous cells, some neutrophils, residual menstrual blood, a little bit of your secretions from the cervical glands, maximally contains secretions from Bartholin's and the skin glands. How do you differentiate whether this discharge is physiological or pathological? যখনই যে কোনো obstetrics বা gynecology outdoor বসবি, if you get 10 patients, 4 of them will come to you with vaginal discharge. This is the most common complaint of all women who come to the gynecological OPD. So how do you differentiate and how do you counsel the patient that this is physiological or this is pathological? Physiological discharge will not be very profuse, will not have foul smelling odor, it will be usually colorless, is not adherent to the vaginal walls. It is not accompanied by pruritus. What is pruritus? What is pruritus? Itching. It is not accompanied by itching, pain, redness or erythema of the vagina. It is not accompanied by burning sensation of micturition or dysuria, frequency, and etc. Any physiological discharge will not be accompanied by foul smelling odor. It will not be accompanied by pain, irritation, itching, erythema, will not be accompanied by increased frequency of micturition or painful micturition. Everything else is physiological. Physiological discharges are influenced by both age and hormonal factors. It is increased in kinds of perimenarcheal phase. Usually OPD তে আসে ওই 10-11 বছরের বাচ্চাকে নিয়ে sudden vaginal discharge হচ্ছে. This is perimenarcheal in response to the high levels of estrogen in our body. Premenstrual phase. Premenstrual phase, there is also some amount of discharge which is physiological. Estrogen causes increased amount of thin watery discharge, whereas progesterone causes thick and sticky discharge. This discharge can also be regulated with whether she is taking any OCPs, she is taking hormonal pills, hormone replacement therapies, or she is on any kind of chemo radiation. Pathological causes. It will enumerate kore dicchi olpo kore shune. This is the important part. Ineffective causes of vaginal discharge. There are 3 major infections: bacterial vaginosis, Trichomonas vaginalis, and Candida albicans. Candidiasis. These are the important causes of vaginal discharge. Etai porte hobe, etai likhte hobe. But if you are asked a question, enumerate the causes of vaginal discharge, you have to write all of these. Vaginal discharge can occur because of vaginal causes. It can occur because of cervical causes. Discharge ta aste pare from vagina, from cervix, from uterus, from tubes. From all of these places, the discharge can come, and all of these will mimic a vaginal discharge. Vaginal causes hocche ja bollam infective, atrophic, postmenopausal. Postmenopausal women often complain of vaginal discharge after oophorectomy. What is oophorectomy? What is oophorectomy? Removal of the ovaries after oophorectomy. Post chemo radiation and something called a premature ovarian failure. All of this causes atrophic vaginitis and causes discharge. Foreign body in the vagina, left out tampon, pessary. Irritant or chemical vaginitis, spermicidal gels and everything. And lastly, any kind of vaginal neoplasm. These are your reasons for vaginal discharges. Cervical causes, এক্ষুনি যেগুলো বললাম, cervicitis করছে, Neisseria, Chlamydia, following any delivery or abortion, and DNC. Cervical erosions and neoplasm can also cause discharges. This is the other part. These are the cancers that can cause vaginal discharge: endometrial CA, cervical CA, polyp, fibroid, copperties, molar pregnancy. Okay. 3 important topic, we'll do one by one. Okay. Normally, what is normal vaginal discharge ki hobe hoy? What is the organism in normal commensal organism in vagina? What is the commensal organism of vagina? Lactobacillus. Why Lactobacillus? Why is it common there? Acidic environment. Ki hoy toiri hoy acidic environment? How is the acidic environment of vagina maintained? Lactobacillus namei ache. What does it produce? Lactic acid. Glycogen হচ্ছে, glycogen কে break down করছে, lactic acid বানাচ্ছে, keeps the pH below 4.5. Okay. So what happens in bacterial vaginosis is this is the most common cause of vaginal discharge, but it is not a sexually transmitted infection. This is not an infection as such. This is basically lactobacillus কে সরিয়ে অন্য commensal organism গুলো overgrow করছে, like your anaerobes and facultative aerobes. Your pH is above 4.5. This profuse grayish white vaginal discharge contains a foul fishy smell, fishy odor in a vaginal discharge, and it is adherent to the vagina. There is no accompanying dysuria, there is no frequency of micturition, and also there is no burning. You investigate a case of vaginal bacterial vaginosis by these 4 things. Clue cells. Somebody tell me what is a clue cell? What is a clue cell? Somebody from there, ball. What is a clue cell? Microbiology hoye geche. What is a clue cell? Anything else? Attu bhalo kore. What is a clue cell? Ki jinishta ki? AC people, ball. Gram negative. What? Not usually rods. Gram negative bacteria. And what is the bacteria? What bacteria? What is the bacteria that's covering the epithelial cells? Yes. It's basically this one, Gardnerella. These squamated vaginal squamous epithelial cells, the entire cell membrane is covered by Gardnerella species and obliteration of cell membrane. These are the clue cells. Any saline mount specimen of a vaginal discharge, wet mount specimen having more than 20% cells as clue cells is considered a test positive for bacterial vaginosis. We have something called a whiff amine test or whiff test. Once you take a specific vaginal swab, you put it under microscope. If you put a drop of 10% potassium hydroxide on it, it will give a foul, fishy odor. This is called a whiff amine test. It is positive in cases of bacterial vaginosis. The diagnosis is done by this one, Amsel criteria. The Amsel criteria has 4 things. This one. Amsel criteria has 4 things. Number 1, thin grayish white discharge adherent to the vagina. Number 1. Number 2 is wet mount microscopy showing at least 20% of clue cells. Your vaginal pH will be more than 4.5 and your whiff amine test will be positive. 3 out of 4, if they are positive, we can confirm the diagnosis of bacterial vaginosis. Akbar treatment of boledi. Bacterial vaginosis is treated by either metrogel, clindamycin or tinidazole. Either of the 3. Commonly we do it by metrogel, 400 TDS BD for 5 to 14 days. The second most important cause of vaginal discharge is Trichomonas vaginalis. This is a protozoa. It is a pear-shaped or fusiform protozoa containing some 5 to 6 flagella. It has a jerky flagellate motility. This one is basically, how do you identify this? The patient comes to you saying she has intense itching on the vagina along with foul smelling discharge, and she will have urinary symptoms, dysuria, frequency of micturition and painful micturition also. Trichomonas will present to you with urinary symptoms because this protozoa invades the urothelium. The urethra and the vaginal epithelium, it invades that and causes urinary symptoms. Bacterial vaginosis patient comes to you with increased secretions and some amount of itching and foul smell. But Trichomonas comes with intense itching, foul smelling discharge. The discharge is usually greenish yellow in color and urinary symptoms. When you examine this patient, you will find that there is profuse frothy greenish yellow secretions. The cervix appears something called a strawberry cervix. In very small amount of cases, but this is a MCQ question, strawberry cervix. And how do you investigate? Again, the pH is more than 4.5. When you do a wet mount microscopy, it shows flagellar motility of Trichomonas. If the Trichomonas is alive, it will show motility. There is on gram stain as well as pap smear, you will find the Trichomonas gram-positive protozoa. Culture and antigen testing. Culture is done in Whittington medium culture and nucleic acid amplification test. Whenever you are in doubt, Your wet mount microscopy is not showing you any kind of trichomonas, but the patient is giving symptoms of trichomonas, you have to go for a nucleic acid amplification test. Since it's a purely STD, sexually transmitted infection, you have to treat the partner and you have to test the partner also. Treatment is again metrozole or secnidazole. Repeat follow-up after 3 months is necessary, and abstinence or use of barrier contraceptives. The last one is vulvovaginal candidiasis. This is again not a STD. It can occur in without any sexual intercourse. It can occur in diabetic patients, immunocompromised patients, HIV patients, patients on immune therapy or patients on chemotherapy, caused by Candida albicans and Candida glabrata. Basically, Candida is an yeast, fungus. It usually stays in the rectum, but can also occur as a commensal of the vagina. Symptoms. This patient presents to you with the most intense itching. তিনটের মধ্যে সবচেয়ে intense itching হবে হচ্ছে ক্যান্ডিডাতে, সবচেয়ে foul smelling হবে হচ্ছে Trichomonas with urinary symptoms, and this will have intense itching. Itching will be both inside the vagina and outside on the vulva. Intense is so severe that you will find scratch marks all over the vagina, this patient. And also you will find some kind of satellite lesions on the vulva, on the labia, outside on the thighs. You can also find satellite lesions. In the, the discharge is cardi-wide. Chhana katar moto discharge, cardi-wide discharge adherent to the walls of the vagina and the vulva. Investigations. This patient will have a pH of, this is the only infection where the pH still remains less than 4.5. The normal pH of vagina is 3.5 to 4.5. আগের দুটোতে above 4.5 হয়ে যাবে. This is the only one যেখানে less than 4.5 এ থাকবে. On saline microscopy with 10% KOH, you will find budding hyphae of the fungus, spores, and yeast organisms. You can do gram stain and culture on Sabarot's medium. Treatment is very simple. Single dose of fluconazole. Fluconazole is an antifungal agent. One single dose, 150 milligrams stat. We can also go for vaginal dosage by clotrimazole, either one single pessary of 500 or 6 consecutive days of 100 milligram. We have something called a recurrent VVC, recurrent vulvovaginal candidiasis, more than 4 episodes in 1 year. You have to do a prolonged treatment with fluconazole, not a single dose, but 3 doses on day 1, day 4, and day 7, followed by weekly doses for 6 months. Your risk factors, this is the thing, symptoms. Your vaginal, bacterial vaginosis will have thin, grayish white discharge. Trichomonas will have greenish yellow purulent discharge, and your Candida will have curdy white milky discharge. I have already done the treatment. Syndromic management. Last part. Pay attention to the last part. Syndromic management, যেটা বলেছিলাম আগের ইয়েতে টপিকে. What is syndromic management? Where we do not wait for any kind of laboratory investigations, we directly go for management of the patient on the first visit. Advantage is it is first visit diagnosis and treatment হয়ে যাচ্ছে, less expensive, all the causes are treated at once, and patient is not lost to follow up. The disadvantages is there is over treatment. একটা ইনফেকশনের জন্য 3খানা ট্রিটমেন্ট হচ্ছে. There is increased antibiotic resistance and side effects. This is this kit. We are concerned with kit 2 and kit 6. The 6 is the যেটা বললাম PID জন্য lower abdominal pain, cefixime, metrozole, and doxycycline, and kit 2 the vaginitis এর জন্য green. One single tablet of secnidazole 2 grams and one single tablet of fluconazole 150 milligrams. This is it, and partner treatment is also recommended.